Well, thank you for joining us today, Phil. How are you doing?
I'm doing well. It's my pleasure. Thank you.
Real. Perfect. So, for people that don't know who you are, we just kind of, if you can give a brief explanation of what you do and your background, really.
Right. Well, my name's Phil Reed. I'm a psychologist. I've been working with women's health team here at Singleton Hospital in Swansea for, oh, 10 or 15 years now. It's somewhere in that region, looking at a wide variety of issues which might affect patient engagement and benefits from physiotherapy treatment.
Oh, bro. Okay. What made you go into that sort of field?
That's a long story and one I'm not entirely sure of myself yet. I was contacted by the excellent physio we have here at Singleton, Maya Havard Thomas, who is really forward looking and always looking for ways to improve the service. And treating her patients in a more holistic is a terrible word, isn't it? It makes you sound like I'm going to get my caftan on any minute. But as a whole person, looking at everything that might impact their lives and how that can sometimes really harm their ability to engage in a treatment.
Okay. So, what would you say, what are your findings so far? What would you say your research guiding you toward in terms of the challenges that you're finding?
Right, we've looked at a number of things, but specifically the kind of barriers and blockages
Yeah.
that ladies report in turning up for women's health physiotherapy.
Mhm.
Um, Now, I can categorize these fairly easily into four blocks, but
Okay.
as we all know, clinically, the world doesn't quite work that way, and these things kind of interact and determine each other. But generally, I would say there are the four major categories of things.
Okay. What would you say those categories are?
Some of them are fairly obvious. So one of the key ones is the way in which the system works. So we have things like simple. So are the referral letters going out in a timely manner? Are patients receiving them? Is there is there adequate transport to the centre you're working in? And that can be a real challenge for ladies, especially if they've got incontinence problems or experiencing pain and maybe relying on two or three bus journeys to get from the outskirts of the city into the centre. And that's hard for them. So it's not a medical issue, it's not a clinical issue, but it's one that clearly impacts on us. Um, it's also just the level of communication as well. One of the things that tends to make ladies drift off and not engage is if for whatever reason they are on a waiting list and nobody is contacting them, even just to say hello, we haven't forgotten you, makes it so much harder for them to engage. So there are those types of system issue, which are some of which we can control, some of which we can't. Um, there are things like just making sure our referral systems are operational, making sure it's not always easy that our contact with the patients is good. So we're always doing what we say we're going to do. And if
Yeah.
they're waiting, making sure there's a call, just a minute. Yes, we haven't forgotten you. Sorry, we're terribly stretched. I hope you just bear with us. We'll get there. Can make all the difference. So those types of issue.
Yeah. So, you're probably going to ask this my next question if there's not one answer to it. But is there something that you found that's the number one in terms of that's something that should be addressed that's not we're not quite achieving?
Of those, I think which is just the first block of them, of those, I think the one that we can do something about is things like just contact and
Right.
making sure that communications are good. Now, I know that we're all stretched.
Mhm.
I know clinical services and support services are enormously stretched, but there are ways around this. You can contact your local universities. You can
Mhm.
and get placement students in. who can help. Many students are desperate for placements in clinical settings, even if it's just being given a list of patients and numbers and a script and saying, please ring these ladies and tell them we haven't forgotten them.
Yeah.
It's as simple as that, and it's cost free. It takes the burden off, and it makes the service more efficient in the long run. And that's what we've found. And a simple call has increased our attendance by 30%. So
Mhm.
the DNAs have dropped dramatically.
Has there been something from your research that the women have said to you in terms of what they gain from that? Obviously, the benefit is the attendance, but what is causing, what's a better way to word it? What are they feeling so they will attend in the future?
Right. I think this links into some of the second block of issues, which is around the patients themselves. Because you've got to remember that, especially in this area of women's health, it comes along with a whole range of worries and concerns and life impacts. So levels of depression are high, levels of anxiety are very high. Many of these ladies have experienced trauma. There's a very strong association between abuse, either in childhood or ongoing, and the two are often related. If you've been abused in childhood, you often get abused later on. It sets patterns. Those ladies are terribly anxious and very, very afraid. Just having a call from a friendly voice can alleviate not only their concerns about have they forgotten me, but also it just makes them exposed to the service in a non-threatening way.
Yeah.
And the more exposed they can be, the more likely they are to turn up and engage, and the more likely they are to get better.
Yes, exactly that. That adherence really starts to, yeah, starts to drive up a little bit more there, doesn't it?
It does, and those psychological issues are really important, because what we found also in the research, and it's not just us, lots and lots of other people have found this, the correlations with depression and anxiety and trauma and PTSD are very high in this group. Certainly the ladies with pelvic floor dysfunction. That not only makes them less likely to turn up, but it makes them less likely to engage. Because if you're depressed, one of the things that we know depression does is reduce your motivation. It reduces your ability to benefit from positive change. So you're less likely to engage, less likely to experience the change, and
Mhm.
therefore less likely to stick the course. And interestingly, even if they do stick the course, even if they do go through their full course of physio treatment, their clinical physical gains are less good at the end of it.
Yes. Okay. What is that because they're not quite engaging fully with it?
Yeah, it's difficult. We've looked at that as a function of, well, is the depression related to the severity of the physical symptoms, which you might expect, and we've controlled for that, and
Mhm.
still the depression is predicting a lack of clinical gain as a result of the physio. It's not clear what that's about. Clearly you could be right, and it could be simply that they're turning up, they're
Mhm.
listening, but they're not going off and doing the exercises
Yeah. Yeah.
in the meantime. That's one possibility. The other interesting possibility is there's some emerging genetic evidence now that suggests that the same genes that are responsible for elasticity and collagen, which would help to regenerate muscles, are also implicated in the generation of neurons in the amygdala, which is an area of the brain that regulates depression and emotions. And so it may be a complex interaction between some genetic predispositions to both and the impact of the depression on their engagement. As with everything, though, it's going to be interesting to unpack.
Yeah. So is that something you're looking into in the future yourself?
That may well be the
Mm.
immediate concern for us is how do we deal
Yeah.
with the psychological issues, and what Singleton's answer was to employ a psychotherapeutic counsellor to work within the women's health team,
Mm.
not necessarily to deal with the psychological issues per se, although that's part of it, but to support the lady while she is engaged with the physio so that they can benefit. And again, that has improved outcomes and improved throughput, if I can use such a terrible term, by about 30 to 50%.
Wow.
And if you do the health economics, it actually saves a fortune doing that.
And so, what were the other two factors part of that research?
Right. The third factor was the quality of the consultation itself. Now, there are two parts of this. The initial consultation with a consultant
Mhm.
can drive what the woman chooses to do. And it's very important the consultant gets the language right.
Yeah.
If they mention surgery as an option up front, then one of two things happen. Either the woman takes to the hills and never comes back, or they think of it as a quick fix and they fixate on the surgery. Even if they are then referred into physio, they don't really engage because they're thinking, oh, this is a waste of time. I just want my surgery. That kind of treatment overshadowing can be easily dealt with by having a chat with your consultant if they're amenable to that. And so, can we think about the way in which you introduce the range of treatment options so that
Mm.
physio isn't, although it's the first line treatment, it's not it's not presented as a sort of a second-rate alternative to what I, the consultant, will do to you, because that really does affect the
Yeah.
patient. That's one part of it. The other is the patient perception of the quality of interaction. Now, if they've had previous bad experiences, usually with the NHS, because that's what we're talking about in our context, they're a bit more reluctant to engage.
Mm.
And you've got to remember that point two is that these ladies are depressed. So they tend to have a negative set. So what we think as clinicians is a perfectly reasonable interaction might be perceived negatively by them. And that then predisposes them in the future not to want to attend. So there's a bit of reflection
Yeah.
that's
And going for and get and going from the starting point and not letting physio kind of pick up the pieces and change mindsets and things like that. Yeah.
it,
Yeah,
absolutely.
as well. Yeah.
So there are those things, those third things that are important. The fourth is difficult. This is other life events. Um, Now, many of these ladies who were referred are referred in at that period of their life when there's an awful lot of stuff that's happening to them. Often they're sandwiched between bringing up their kids and beginning to care for their parents.
Right.
Given the mindset of many women, they will always tend to put other people before themselves. So they're at the bottom of the queue and they simply do not prioritize their own health. Or if they do, they prioritize it for the sake of others. So they will say, I'm coming here because I want to get better to look after my husband or look after my mother, rather than I want to get better. and that makes a difference. If they want to get better, they will, because they'll engage. If they're doing it for external reasons, it's an uphill battle. So there are all of those issues. The other issue is many of these ladies have problematic lives. As we've mentioned, and as I'm sure that people listening to this will be very well aware, there's an awful lot of domestic abuse out there. This can be historical and ongoing. There are socioeconomic factors, things like housing problems, benefit problems. Depending on where you live, there can be immigration problems as well. All of those legal problems cause the psychological issues, and if they're violently abused, can cause some of the pelvic floor issues. So they're intimately connected to the condition that we're dealing with. But we as clinicians cannot treat those. And the number of times I've heard the counsellor in the team or the physios say something like, this lady doesn't need a physio or a psychologist. This lady needs a solicitor to deal with these issues.
Mm.
One of the things that we've just done is established a health justice partnership, which will allow clinicians to refer ladies with their consent, obviously, directly from the NHS to legal aid solicitors.
Okay.
So we have agreed with the local health board and a consortium of local legal aid solicitors that we can use an online referral system, which is private and confidential, which will allow the clinician to give the solicitor those details the solicitor needs in order to take the case on. The benefit of this is the women's health team has another weapon in their arsenal to help treat these ladies. The lady themselves doesn't have to find a solicitor, and they know that what legal help they get will be free at the point of delivery, because there's a checklist of things the solicitor has given us to say, if you tick any of these boxes, we can do legal aid. That
Really, really interesting.
Yeah, we've just started that because we found some horrendous numbers of our ladies. And whether that's because we work in an urban area, I don't know. But somewhere between 50 and 80% of them were coming along with a legal problem of some sort, and frighteningly high numbers were involving domestic abuse and or divorce.
Mm-hmm. So is that the health justice? Is that in place now? Is that still
Yes,
a bit? It is. Oh, wow, that's great.
it is in place now, and one of the things I was kind of excited to talk about was this, because we think it's really interesting innovation. It has worked in other countries. So Australia have used this type of system for some time
Right.
now,
Okay.
and we're a little bit behind the game here.
Mhm. At least we know it's going to work. We know it's going to be a great step in the right direction.
Yeah, there's evidence that it does work. I would really encourage people to explore those possibilities, and I'm very, very happy and keen to chat to anyone who wants to chat to about how to set those up. One of the easy things, just form contacts with your local university law department. There will be somebody there who is interested in this area, and probably there will be some system that you could use. If not, I'm very happy to have a chat about how to set those types of things up.
That's great. So moving forward, just going to take a question now from our listeners. And the question was, what is the one piece of advice you would give to physio from the research that you've been doing? What would you suggest a physio should be doing differently, or at least more of?
That's a really difficult piece of
Yeah.
philosophy, and I hesitate to give that sort of
Yeah,
advice.
because
But
obviously it's
I
going to be a whole mix of things. But
yeah,
in terms of
I
what
think
do you feel most passionate about?
I think the truth of the matter is trust yourself, because you're probably doing everything you need to do, because physios are very good at treating a person not just as a pelvic floor. They understand in a way that oh, I don't want to belittle other of our medical colleagues that they don't necessarily just see this person as a bladder or a bowel, but there's a person wrapped around that, and physios tend to do that anyway.
Yes,
And
definitely.
you've got to. And I think it's about trusting your judgment and reaching out to other members of the wider team and community around you to help develop the service, because we all know you cannot do everything on your own. Physio is a fantastic treatment. We know it's effective. We know it's cost efficient. We know it's safe. We know all of those things. But we also know that it requires two. It requires the physio and the patient.
Yes.
You know this. You know
Mm.
this as physios already.
Yeah.
Um, you
It's
got to
trusting it.
you got to trust yourself. You got to trust your judgment, and don't be afraid to start reaching out to get other people on board into a team. Um, and I think that's the single biggest thing we can start doing differently, which is working as a team, working multidisciplinary, and developing the resources that you have. And I say that with full understanding of the constraints that we're all facing with the
Mm.
NHS. There are resources out there that you can utilize, and they're free. Talk to your line managers, get them on board, start utilizing that stuff. The other thing I would say that really makes a big difference is just get your comms right. Get the basics right. Make sure your patients are on board, and make sure they know what's going on. They know what to expect, when to expect it, and just make sure it's done.
Good communication, right?
But,
Keep them in the loop.
yeah, I think so. And again, I know it's hard. With decreased resources, decreased ability to do those things, it's tricky. But again, think of what's in your area. What can you reach out to? Who can help you? Who might be keen to help you? Um, if all else fails, get the patients involved. Form patient partnerships. Reach out to those patients who you know could do a good job. Get them on board. Maybe they can ring people. Maybe they can help you. Maybe they'd like to.
Yeah, that's really good. It's really, really interesting. Sadly, we're going to have to wrap it up here now. But thank you so much for joining us today. It's been really, really insightful.
Well, I thank you very much for inviting me. I don't mean to say that you need to do any of these things, because I know that physios are doing a fantastic job under very difficult circumstances. Um, there's just a lot of extra stuff you could do,
Yeah,
um, just based on stuff that's available to you, and I would do it. And if not, no one's, don't look to managers to help you. Do it yourself.
a really good piece of advice. Thank you so much. And we'll chat again soon.
That would be great. Thanks very much for inviting me.
Thank you.